that premise I talked about of clinical endocannabinoid deficiency, the first question we asked was whether or not if we mimicked that by somehow lowering the levels specifically of 2-AG because it had been understudied, could we actually induce a headache? Okay. And so that was the first thing we did. We found a compound that would selectively block the enzyme that makes 2-AG. So that enzyme is called diacylglycerol lipase. So we blocked DAG lipase and found that a systemic administration of this compound would selectively reduce 2-AG levels within the central nervous system in two brain regions implicated in migraine, one being the visual cortex, which is where cortical spreading depression, the physiological correlate of migraine aura, is generated. So 2-AG was lowered in that area, as well as in the periaqueductal gray, which is a midbrain region implicated in descending pain modulation. And not only were these levels of anandamide lowered in these regions, but our preclinical models, our subjects developed headache-like behaviors, specifically cephalic hypersensitivity to touch or cephalic allodynia, without developing whole body allodynia. And so why is that important? So we typically associate cephalic allodynia with headache-like pain. Whole body allodynia is generalized allodynia, and that's most frequently associated with patients who have chronic migraine. So in this particular set of experiments, what we found was that we could induce something more akin to episodic headache. The behavioral outcomes were more pronounced in females as compared to males. It was dose dependent, meaning as you increased the dose of this inhibitor, the magnitude of the cephalic allodynia was greater, and it lasted for a longer duration. Not only that, more of the subjects were showing this allodynia as the dose increased, right? So it seemed to be very, very much tied to maintaining levels of 2-AG. So if you deplete the levels of 2-AG, you could induce a headache, is the take-home message there, suggesting that 2-AG itself is helping maintain a homeostatic level so that headache is not induced under normal circumstances, right? So just because there's headache-like pain in the head doesn't necessarily mean it's a headache. So we did several other follow-up studies. One was where we looked at the use of triptans, specifically Sumatriptan, as well as the first generation Gepant. So the Gepants are the CGRP targeting agents. So we used Olcegepant, and these are two migraine-selective drugs. So they don't work for other types of pain. So if this was actually a model of headache-like pain, then we would expect those two drugs to attenuate the behavior. And that's exactly what we saw. So this really did confirm to us that this was a headache-like model. So the take home is that if you lose 2-AG levels in a normal animal, so there's no other injury, there's no head cap, there's nothing going on, and we just deplete these levels, we actually can induce a headache. And then that begs the second question, right? So that was the detrimental component. So if you lose 2-AG, you have higher susceptibility to headache if you're a female. So the second question was on that beneficial arm. So could we replace 2-AG levels and mitigate headache induced by other things? And so within that kind of question, the first thing we had to know was, do other models of headache, things like medication overuse or sustained administration of drugs, to mimic that state in the clinical patient, does that reduce 2-AG levels, right? And that's exactly what we found. So using two different models of sustained medication administration, both of triptans and of opioids, so these are two drugs that are associated with medication overuse headache, we were able to see reduced levels of 2-AG, again, in specific brain regions, notably the periaqueductal gray. We also followed up with a second model that's clinically relevant, where we induce cortical spreading depression. Again, that is physiological correlate of aura. It's also associated with the cephalic allodynia, as well as whole body allodynia. And in that model, we also saw loss of 2-AG levels in the periaqueductal gray. So this seems, really coming down. So using that cortical spreading depression model in the preclinical setting, what we asked was, can we restore 2-AG levels by preventing its breakdown? So if we already know that the model is reducing the levels, we don't want to play around with that part. We just want to be able to normalize them, right? And so that's what we did. We used 2 separate drugs in 2 different paradigms. So the 2 drugs target these degradative enzymes for 2-AG. So monoacylglycerol lipase, which is expressed on the presynaptic terminal, and it controls levels of 2-AG after it has signaled at those cannabinoid receptors. And so I'll talk about that one first. So we gave it both in this preventive as well as a reversal paradigm. And in the preventive paradigm, we were able to shorten the duration of the migraine, but the magnitude of the migraine remained the same. In the reversal paradigm, we administered this compound, a selective inhibitor, after the establishment of the cephalic pain, and it was able to mitigate that pain within 60 minutes. So it shortened the duration and the magnitude in that reversal paradigm. The other strategy we took was to target the other degradative enzyme, and this enzyme is called alpha-beta-serine hydrolase 6, or ADHD6. And this enzyme is actually expressed on the postsynaptic terminal, and it controls the amount of 2-AG available for retrograde release. And so that's one thing I didn't necessarily mention at the beginning. Unlike traditional neurotransmitters, which are stored in the presynaptic terminal, and then they're released to act on the postsynaptic side, the endocannabinoid system is a retroactive neuromodulator. So it's made in the postsynaptic side, and it's released to have actions on the presynaptic terminal as a negative feedback to turn off neurotransmitter release. So the second question was, if we elevate the levels of 2-AG available for release, prior to stimulation in this paradigm, can we prevent the headache? And the answer to that was yes. And so that was really exciting, because these animals never experienced significant cephalic allodynia in the prevention paradigm. And then, just like with the MAG lipase inhibitor, we administered the ADHD6 inhibitor 30 minutes after induction of headache-like pain. And again, we're able to completely mitigate the cephalic allodynia. So we have these 2 different things. So one, loss of 2-AG can be a driver of headache pathogenesis, and but it's also, that loss is also implicated in the maintenance, right? Because that's what the reversal paradigms really suggest to us, is that restoring 2-AG, prevents that whole maintenance. And so the question then became how. And if you don't mind, I'll just kind of go straight into that. And so one of the unique things about the endogenous cannabinoid system, or the endocannabinoid system, is that these lipid mediators, anandamide and 2-AG, have their own receptors to the signal at, as I just discussed. But they also, when they're degraded into these two components, arachidonic acid and glycerol. Why is that important? Arachidonic acid is the precursor for inflammatory mediator generation, right? So if you have arachidonic acid, that is then processed into things like prostaglandinoids. And those prostaglandinoids can be largely pro-inflammatory. Some are anti-inflammatory. And so by blocking the 2-AG degradation with the ADHD6 inhibitor, as well as the MAG lipase inhibitor, we end up having two different effects. One, we can boost where these lipids are acting, so where 2-AG is acting, but we're at the same time reducing the ability of the cell to make pro-inflammatory mediators, right? And so that's really what we were trying to find. And so during the presentation, I alluded to that. I didn't show the data, but I did show that we do see increased activity of 2-AG at the CB1 and CB2 receptors.